I cannot see it on my end. Is it being recorded or not? Okay, now it is. So again, Assalamu alaikum and good afternoon, everyone. And it's probably good night in Pakistan as well. So I think today we will talk about Ig-A-Nephropathy. We have two wonderful speakers, and you already saw the panel and we have a case. But before we go to the main thing, I will ask Jessica Byler, who joins us today from Penn State Project ECHO, to give us another update about the Project ECHO and moving forward, how we will have sessions in conjunction with the Project ECHO where you can register and get CME credits. So Jessica, over to you.
Thank you, Dr. Farooq. Good afternoon, good evening, everyone. Thank you so much for joining today. So yes, we're moving the next session, so the April session, to the ECHO platform. And the main reasons for doing this, because Dr. Farooq and the team has already adopted this wonderful model of giving some information that everybody can learn from, doing the case and doing the discussion, which is what we do at Project ECHO for all of our series. So you guys are already way ahead of the game and super innovative. But we're going to just help things be a little bit easier on Dr. Farooq and the team by taking over some of the communications. And then to do that, we need everyone to register for the series. So even though right now you're getting Zoom links, you're part of the group, we're asking you to register. I put the link in the chat. What that's going to allow us to do is reach out to everybody via email. It's going to let you claim CME credits for participating in these series. It's going to allow you to provide evaluation feedback so that if we need to, pivot, if you have suggestions for other topics, that sort of thing. So it's a kind of just a better, more organized back and forth. And that's not to say things haven't been organized. We're just trying to take that off of your plates and put it onto our ECHO plates. So if you could, I will definitely share the link again. And I will also put the flyer in there. And so if everyone could do their best to register before that next session on April 11th. So we're planning on sending out the reminder emails with the Zoom link and the information that you would need around the 8th of April. So if you could try to do that ahead of time, that would be lovely. Also, we will, this link that's attached is public. So you can forward it to any of your colleagues that you think would be interested in participating. No one has to keep track of it. They'll register and then they'll be part of our contact list. So did anyone have any questions? I'm also going to plop our beautiful, I don't mean quotes in beautiful, but it's like fancy looking flyer that you could also download and then email it to people with less explanation than what I'm giving you now, in case you have colleagues that are interested in participating as well. Did anyone have any questions? We're just hoping it makes it a little easier on everyone, and then you can get CME credits.
Thank you, Jessica. I would like to share that I spent 3 minutes and probably 40 seconds to complete the registration process. So there is a brief survey which will actually help us to generate, to measure even some of the outcomes which we will, at the end of the series, we can measure those outcomes. So please fill this, use the link, fill the survey. It's less than 4 minutes and just one time. So maybe every time for CME credits, you may have to evaluate all of us, but please register. So with that, if anybody has questions, I will give 2 seconds. If not, then we will move to the next. Okay, it looks like no more questions. Thank you, Jessica. All right, I will share my screen and ask Dr. Aurangzeb Afzal to present the case. Can you all see my screen? Case Nazar, can you see the case on the screen?
Yes.
It says GN kidney transplant. Okay, here we go.
All right. Can you hear me?
Yes, you can.
Okay, so this was a case, and I must add that this presentation is made by that patient, and which turned out to be my house officer once, and he's a doctor. And I did not change much because I just wanted to be in the words of patient as well as the doctor. So that's what he says about himself. My patient, 27-year-old male, was in usual start 4 months ago, and he's to develop hypertension. And he's a thin, smart guy. He occasionally started atenolol 50 mg for blood pressure, and that was a self decision. He did not ask me. And he went for a routine blood test at the end of January 2021, and that turned out to be 1.49 milligram per deciliter for serum creatinine. And the one is also there. But after 1 week of that serum creatinine, it went from 1.49 to 1.67, which means that where there was an acceleration in terms of deterioration. Next, please. Renal biopsy was done. Next slide. All right. The rest of serology is at the end. This is just how he made it, so I just let it be. So the renal biopsy was done. Renal biopsy showed just 4 glomeruli, and the biopsy is composed of cortex, medulla, corticomedullary junction, and no globally sclerotic glomerulus. All viable glomerulus increase mesangial cellularity and mesangial matrix expansion. One glomerulus shows segmental sclerosis, and sclerosed area was adherent to the Bowman's capsule. There is a fibrocellular crescent in one glomerulus, and the Bowman's capsule is ruptured in this very glomerulus. If you see, these are 4 glomeruli, and there is one glomerulus, so that makes almost 25%. The inflammation, moderate chronic inflammation, the fibrosis, mild interstitial fibrosis, 20 to 25% is noted. And this, remember this 20 to 25% because I'm going to discuss the risk prediction score. So this score is going to be important then. And there is mild tubular atrophy. Moreover, mild tubular injury is identified, corrected by the loss of brush border and this and that. Vessels unremarkable. Next. Next, please. Yes. So in immunofluorescence, there is moderate to marked mesangial staining with IgA. The CG was also moderate to strong, but there wasn't anything else in terms of IgG, M, and C1q. The diagnosis was Ig-A-Nephropathy with mesangial and extracapillary proliferation and segmental sclerosis. The MES score is written along with C1. And mild interstitial fibrosis 20 to 25%, and moderate interstitial nephritis. Next, please. So 24-hour urinary protein was 1.2, UPCR was 1.3. The GN screen was negative, as was the normal IgA levels in the blood. Even the ANCA was negative, and we did both ANCA C and P. No history of chronic NSAID abuse, Hakim medication, herbal medicine, no family history of CKD. Next, please. And before treatment, I must add that there wasn't any history of any celiac disease, HIV, of course, there wasn't any cirrhosis. And autoimmune disease, there wasn't any history of autoimmune disease with that. So the association history was pretty negative. So usually we are going through a bi-weekly roster. So the biopsy was done when another team was taking care of the ward. And this is what they decided, that solomedrol 1 gram should be given. And after that, 1 mg per kg steroid was started. And this is what happened. The serum creatinine is at 1.46. And then finally, after 1.46, it again went on to 1.53. So now it's almost 4 weeks, if I'm not wrong. Next slide. Okay. So it's almost 4 weeks with 1 mg per kg prednisolone along with solomedrol 1 gram that was initially given. Now, if I may add, with 25%, by definition, it's not a crescentic IgA, but we are going to discuss what is the percentage of crescents in Ig-A-Nephropathy in different populations, and how should we proceed with it. Now, the house is open for any comments and suggestion what to do next.
So I just stop share. So I think brilliant case, and thank you for presenting the case as well. It's really important to look at the actual case, and I'm so happy that you presented as this was sent to you. I just changed the format, but the words were same. So at this point, I would like to invite Dr. Mateen Akram and Dr. Mudassar Hussain. Dr. Mateen is faculty at Sheikh Zayed Hospital, and Dr. Mudassar is the histopathologist with expertise in renal pathology at Shaukat Khanum Memorial Trust Hospital. So they will talk to us about Ig-A-Nephropathy. I think they have a wonderful presentation, and both will discuss their relevant sections. And once that's over, then we can have some open discussion that what to do next for this case. So Dr. Mateen, do you want to start by sharing your slides, please? You can unmute yourself as well.
Thank you very much, Dr. Umar. Are you seeing my presentation?
Yes, we can.
Yes. Okay. Thank you. Thank you very much, Dr. Umar, for inviting me to present Ig-A-Nephropathy in this forum.
Do you want to? Yeah, this is
yes.
good.
Just to start with the introduction of the Ig-A-Nephropathy. The Ig-A-Nephropathy is also known as a Berger disease. Jane Berger, who was a histopathologist, described the histopathological findings of the IgA in 1968. This is the most common form of primary glomerulonephritis, which almost affects 200,000 to 350,000 people per year. This disease is associated with poor socioeconomic status and with a very diverse geographical distribution. For somehow, that's Ig-A-Nephropathy is more frequent in Asian population and is much less frequent in African population. When we will see the global distribution of patient with Ig-A-Nephropathy in some key region of the world, this prevalence is shown as a percentage of biopsy-proven Ig-A-Nephropathy. And you'll see that in the Singapore, in China, in Japan, this is highly prevalent as compared to Europe. This is very less in United States and also very less in the France as well. Regarding the pathogenesis of Ig-A-Nephropathy, this is autoimmune disease. It is resulted from the formation of dysregulation of mucosal IgA in response to that of infection of food antigens, associated with the increased form of pathogenic IgA, and is also associated when there will be a decreased clearance from the systemic circulation by liver or mesangial clearance as well. Before going into the pathogenesis, I will just describe the normal structure of that of the IgA. The IgA is unique in the form of having a O-glycans. This in the hinge region of IgA. The characteristic feature of this O-glycans that there is the attachment of firstly N-acetylgalactosamine in the first step. In the second step, there will be attachment of galactose, and then the third step there is attachment of the sialic acid. This is the normal structure of the IgA. So whenever there will be a abnormal shape in the form of, you will get the attachment of sialic acid after that of galactosamine instead of galactosamine. So instead of galactose, you will get the galactose deficient IgA, and this is the main culprit for the formation of Ig-A-Nephropathy, and this is called as a poorly galactosylated O-glycans or galactose deficient IgA. There is a for the pathogenesis, there is accepted model. This is the 4-hit model for the pathogenesis of IgA. And in this figure, I will describe the 4-hit involvement of the pathogenesis of IgA. The firstly, there is a bacterial infection which cause the increased formation of the B cell activating factors and the inflammatory ligands, which will increase the B cell formation, and that causes the increased formation of IgA. This IgA is a dimeric, and this is galactose deficient IgA. In the second hit, you will get the formation of antibodies against this galactose deficient IgA. In the third hit, there is a formation of immune complexes, and in the fourth hit, you will get the deposition of these immune complexes in the mesangium, and this will cause the local damaging to that of the mesangium by the activation of complement system. So in the first hit, there are two subclasses of IgA. 80% of the serum is IgA1, and this Ig-A-Nephropathy show the greater proportion of the poor galactosylated IgA. This poor galactosylated IgA is polymeric and produced at the mucosal surface as a part of innate immune response, and when there will be an abnormal innate response, there is a production of this galactose deficient IgA. In the mucosa, there is mucosal toll-like receptor activation, which will induce the B cell activating factors and also causing the B cell expansion and increase IgA synthesis. Activation of the toll-like receptor also causes the proliferation of other inflammatory markers in the form of IL-6, APRIL, and these together to promote the generation of galactose deficient immunoglobulins A. So in the second hit, there is a formation of anti-glycan antibodies. This anti-glycan antibodies correlates with the amount of proteinuria, and increased level also correlates with the histological features of the mesangial and endocapillary proliferation. In the third hit, there is a formation of immune complexes. These immune complexes will activate the complement system, especially the alternate pathway, and there is a deposition of C3 in 80 to 90% of the patient. These pathogenic circulating immune complexes contain the glycosylated polymeric IgA1. The response of the mesangial cells in the formation of due to that of the immune complexes, as these mesangial cells represent the primary target of these pathogenic immune deposits, and this deposition of immune deposit increase during the episodes of macroscopic hematuria. What happens in the mesangium after the deposition of the immune complexes? In the fourth hit, there will be a extracellular matrix expansion with the complement activation and the cytokine release. This cytokine injures the podocytes, will alter the glomerular filtration, and will induce the proteinuria. Mesangial cells have the IgA receptors, and this tissue deposition of IgA immune complexes cause the local complement activation. As the mesangial cells maintain the glomerular stability, and whenever there will be an effect on the mesangial cells, this will cause the effect on podocytes as well and causes the podocytopathy. This mesangium podocyte link disruption will cause the proteinuria and tubulointerstitial damage. And also the cytokines, which are the tumor necrosis factors, IL-6 and angiotensin II, they will induce the inflammation, which will subsequently cause the glomerulosclerosis. And this mesangial expansion and the podocyte damage will cause the hematuria. So this is the sum of that of the product of that of fourth hit. In the first hit, you will get the circulating antibody, you will get the galactose deficient IgA, then antibodies. In the third hit, formation of immune complexes. In the fourth hit, you will get the mesangial deposition of immune complexes and causes the activation of complement. Regarding the role of complement in Ig-A-Nephropathy, the main pathway which is stimulated in Ig-A-Nephropathy is alternate pathway. This will be evidenced by the involvement or deposition of the C3 in Ig-A-Nephropathy. This glomerular C3 deposits may be differentiating to the asymptomatic IgA, which is found into 4 to 16% of the population. The other evidence that the alternate pathway is activated in Ig-A-Nephropathy is the presence of factor H-related proteins 1 and 5, which indicate the involvement of alternate pathway. When there will be a deletion of FHR1 and FHR3 genes, this will associate with the protection from IgA. And this protective role is more prevalent in Africa as compared to Asia. That is why the prevalence of IgA in Africa is lower as compared to Asia. And also there is a negative role of factor H related protein with the EGFR. When you will get the high level of FHR, you will get the low level of EGFR. So the factor H related proteins are also associated with the histological marker of renal injury as well. The lectin pathway is also involved in the Ig-A-Nephropathy, and these are the important mediators in the respiratory and the gastrointestinal tract. The glomerular lectin pathway deposition relates with the Ig-A-Nephropathy. The fragments of the C4 and C4D also been identified, and which will be discussed by Dr. Mudassar, who is histopathologist. And there is also a clue that the lectin pathway is involved in Ig-A-Nephropathy. Regarding the terminal pathway, this is the membrane attack complex deposition associated with the renal inflammation, and there will be a progression of glomerulosclerosis. So as a result, the complement and its different components seem to exert a fundamental prognostic influence in patients with Ig-A-Nephropathy. Regarding the clinical presentation, 40 to 50% of the patient can present with the gross hematuria. This will concurrent with the respiratory tract infection, and it is also called as a synpharyngitic hematuria. The age is more in second decade of life, associated with loin pain, malaise, and fever. Hypertension and the peripheral edema is rare in presentation of gross hematuria. This will rarely occurs after the age of 40 years. 30 to 40% of the patient present with the asymptomatic hematuria and proteinuria, which will be discovered on routine examination. Protein is variable, but oftenly it is less than 1 gram per day. Nephrotic syndrome present with 5 to 10% of the patient, which can present with the advanced glomerular disease and hypertension, and the patient can present with the normal kidney and normal tension as well. Less than 5% of the patient present with the necrotizing GN with crescents. When the patient of Ig-A-Nephropathy present with the necrotizing GN with crescents, this is having a more poor prognosis as compared to other necrotizing GN. 5% of the patient present with the chronic disease may or may not be with hypertension. This is most commonly in elderly and remain undiagnosed because of lack of gross hematuria, and patient can present with the chronic GN and with hypertension as well. Acute kidney injury is less than 5%. 27% of the patient is older than 65 years. They may present with the necrotizing GN and having present with the tubular obstruction due to RBCs in heavy hematuria as well. This is the graph of the various age group for the presentation of Ig-A-Nephropathy. As you will see, the IgA vasculitis is morely in the early age group in the children, which is followed by the macroscopic hematuria, which occurs from the age of 5 to 40 years. Asymptomatic urine abnormalities from the 15 to 60 years of age. Nephrotic syndrome can present with that of the 10 to 15 years, and the chronic renal impairment in the later age group. These are the some diseases which are associated with Ig-A-Nephropathy. You will get the, in the rheumatic and autoimmune disease, you will get the ankylosing spondylitis, rheumatoid arthritis, uveitis. In the GI tract, celiac diseases, and in the hepatic diseases, alcoholic liver disease, non-alcoholic cirrhosis, and the schistosomal liver disease. Lung diseases, you can get that of the sarcoidosis. In the skin, there will be a dermatitis, herpetiformis, and in infection, you will get the HIV and hepatitis B. So in the differential diagnosis of Ig-A-Nephropathy, you have to look for the IgA vasculitis, lupus nephritis, alcoholic liver disease, IgA monoclonal gammopathy, schistosomal nephropathy, and IgA dominant staphylococcal GN. I will stop here, and the treatment will be discussed after the presentation from the histopathologist, Dr. Mudassar. Dr.
जी जी
Mudassar, can you?
जी बिल्कुल, मैं शेयर करता हूँ. फर्स्ट ऑफ ऑल आप
जी डॉक्टर मुदस्सर.
जी जी. Now the screen shared.
Yes.
My screen shared.
हाँ जी, स्क्रीन आ रही है.
Okay. Okay. Thank you very much. First of all, I thank you very much, Dr. Mateen and Dr. Omar Farooq, for providing me this magnificent opportunity. All of you know that, I think definitely you will know, that Ig-A-Nephropathy is a very heterogeneous disease. We can see just a normal biopsy, we can see segmental sclerosis, crescents, mesangial proliferation, endocapillary proliferation. Every kind of pattern can be seen in the Ig-A-Nephropathy. So as far as this case is concerned, first thing is that we can see that there are 4 glomeruli, and in the background, that the tubules are back to back. There is no much tubular atrophy or interstitial fibrosis. There is mild changes in the tubules in the form of dilatation. There is haline cast, and there is some loss of brush borders. So just hold on, this is some problem. So, and in the next slide, and the high power, we can see that this is one of the representative glomerulus. This is another, we can see that there is increase in the mesangial cellularity. There is no endocapillary proliferation in the form of neutrophilic infiltrate or more endothelial cell proliferation. There is increase in the mesangial cellularity here also, in this clone also. So there is increase in the mesangial cellularity. There are, I think there is definitely, this is a cellular crescent, but there is no breach in the Bowman's capsule in this glomerulus, and there is no much periglomerular fibrosis or periglomerular involvement by the breach of Bowman capsule by this crescent. So there are few areas which show some tubular atrophy, and there is some interstitial fibrosis. I can show you in the trichrome stain. So on the highest part, this representative glomerulus show cellular crescent, increased mesangial cellularity, and this part of the globe, we can see that this is adherent to the Bowman's capsule. So segmental sclerosis is also there. So we have segmental sclerosis, we have increased mesangial cellularity or mesangial proliferation, and we have extracapillary proliferation in the form of crescent. So in the trichrome stain, in order to see how much is the quantity of interstitial fibrosis and tubular atrophy, we can see that there are no much areas which are blue. So there is no massively atrophic areas or interstitial fibrosis, but there are few areas definitely are there. These areas, there are some bluish tinge here, these areas, but overall, they are not more than 50%, and they are almost 20 to 25% is the real percentage of interstitial fibrosis and tubular atrophy. And this is the JMS stain or the silver stain. In the silver, we can see that the tubules, they are back to back. There is no much tubular atrophy, but there is some tubular injury in the form of this sloughing off of epithelial cells. Here in this tubule, we can see that this brush border is intact, but there are several tubules where the brush border is lost, and there is some sloughing off of epithelial cells. We can see that this is the segmental sclerosis, and area is adherent to the Bowman's capsule, and this is pretty normal glomerulus. This is another picture of silver stain, and as far as the immunofluorescence is concerned, So this is absolutely a typical morphology of IgA deposition in the mesangium. We can see that these are the mesangial areas where there is marked or strong IgA deposition in the mesangial areas, and there is no membranous deposits. And in this case, C3 was also present. So IgA was present. If you see that the IgA is to some extent more stronger than the C3, but C3 definitely deposits are there in the mesangial and the paramesangial areas. So as far as morphology and the Oxford scoring is concerned, this is definitely Ig-A-Nephropathy with segmental sclerosis, with one crescent, and with increased mesangial cellularity. Oxford classification and diagnosis is M1, no endocapillary proliferation, S1, segmental sclerosis. So tubular atrophy is less than 25%, so it would be T0. If it's more than 25%, to 50%, it would be T1. If more than 50%, it should be T2. And C1 is the crescent. And so if it's more than 25%, sorry, more than 50% crescents are there, then it would be C2. So it's less than 55%, so this is C1. There should be mild, not moderate. Mild interstitial fibrosis and tubular atrophy, which is 20 to 25%, but vascular changes were there. I can show you in the first slide, vascular changes were there, I think, yeah, here. This is the artery, which is more thickened, but this is the lowest part. And this is the arteriolar hyalinosis and arteriosclerosis there. So definitely the presentation was hypertension, and there are changes in the vessels also. So this is it from my side, I think.
Can I ask a very quick question?
Yep.
So when we are calculating the percentage of crescents in a sample, what kind of specimen adequacy do you require to make a determination? If you've got two gloms and one of them has a crescent in it, now technically that's 50%, but
Yeah.
you may have actually in other slides another 30 gloms with no crescents. So the interpretation of that would be very different. And the corollary to that is, do you interpret, obviously when you're reporting the MEST, that's one thing, but do you interpret the importance of the crescents? And that's more of a clinical question, with or without the presence of endocapillary proliferation.
Yeah, of course, in terms of adequacy wise, this is not an ideal biopsy, but I think 20 glomeruli, it's basically is called as adequate criteria in the native kidney. And in the transplant kidney, there's at least 10 glomeruli and the 2 vessels. But in the native kidney, there should be at least 20 glomeruli in order to call an adequate biopsy. But we have to report whatever we see, actually.
Thank you.
Thank you.
Yeah, one quick comment, if I may. Like C1 and C2 differentiation, if I'm not wrong, 25% or less crescents, that's C1, and 25% above, it's C2. And for T1, in T1 and T2, it's 26 to 50% in T1.
T1.
Is that so?
Yeah,
All
absolutely.
right. So, okay. So now the question that Dr. Aga posed was that endocapillary proliferation is absent, but still there is crescentic glomerulus. Now that brings us to a very critical question. And if we want to start this discussion, this is the, I think, main crux of this presentation. And keeping that case here, will, if we are able to touch the basic scenario, how to interpret this kind of biopsy and translate into a clinical decision, that's what we are trying to learn from each other. Problem is, for example, the crescents, the MEST initially did not have crescents. Then they added C. And even now, if we are calculating on international risk stratification score for Ig-A-Nephropathy, they don't have crescent in that criteria. They have 13 things to be added, 12 digits to be added, and the 13th one is whatever the number of months you want to enter in order to see what's the prognosis then. And they don't have crescent in it. The point is all the data that we have from mostly Ig-A-Nephropathy testing 1, testing 2, most of them don't have crescent as a important marker for predicting any kind of future problem. Even in that MES score regional where that was made, I think in the first one, they did not consider crescents to be important. In the second one, when the cohort was made for China and Europe, they finally decided the crescent should be entered. But is it correlated with the endocapillary proliferation? Or is it the endocapillary proliferation and the crescent together? Then we should be opting, even with a single crescent, we should be opting for something bigger in terms of treatment. So that is what I want to learn, if somebody can comment on that. And would that matter if the crescent is there without endocapillary proliferation?
So this is the question for nephrologists or histopathologists. I think histopathologists may not be answered the question.
You know, that's the thing. The score that MEST or MEST-C is giving us,
Yeah.
I don't know how to use it. It's a car that is there and it's a beautiful car. It's a branded car, but I don't know how to utilize it. And the same is true for that international risk stratification score. Even if for a score, let's suppose if we are going for a higher score and we are trying to tailor that the higher score should be treated as an immunosuppressive candidate. You know, T3 is something that I may not go for treatment. And on the other hand, if the score for mesangial proliferations M0 is considered to be good and M1 is considered to be bad, so which way we are going? The lower score is good for immunosuppression or a higher score is good for immunosuppression?
Yes,
Okay, one thing.
I think
One,
those go ahead.
sorry, Dr. Irfan. So I'll finish in there only 1 minute. And I think endocapillary proliferation is basically a definition whenever there is inflammation and the acute inflammation with more endothelial cells. Okay, we see endocapillary proliferation in the SLE, we see in the post-infectious GN, but whenever they have the crescents, the things are added. Okay, this case has crescent with endocapillary proliferation. So these are different things as far as I know. These are the entirely different things. They are not linked together. But the proliferative GN, they have the different type of morphologies. They have endocapillary proliferation, they have extracapillary proliferation in the form of crescents. But I think they are the two different things rather than linking it with one another.
Yeah, so I think the entire exercise in glomerulonephritis and especially in IgA-nephropathy, because we don't understand the disease well at all, is to figure out what features portend a bad prognostic inclination for that patient, and also who are the patients who are going to benefit from therapeutic immunosuppression. That's the whole conversation in IgA nephropathy, and that's been going on for forever. And the answers are still not clear. So IgA nephropathy, in 10 years, in 15 years, we will identify as a group of disorders, not one disease. And it is not one disease. We know this even today. There are some IgA nephropathies that we incidentally pick up in donors. You know, they've got a little bit of hematuria and we biopsy them and it turns out, well, you've got IgA nephropathy. And nothing happens to them forever. Some of these are autopsy diagnoses. And then there's IgA nephropathy where you will have massive endocapillary hypercellularity, crescentic transformation, and a rapidly progressive glomerulonephritis that will burn the kidney down in weeks to months. Surely these two are not the same disease, but we will label them both as IgA nephropathy as we understand it. And even more troublesome are the disorders that are kind of in the middle. And I think the case that Dr. Aurangzeb presented is very, very representative of the dilemma that we face every day in clinic, where you've got somebody with IgA nephropathy and 1.5 grams of protein and some renal dysfunction. What do you do with them? Are we going to bend their 10-year ESRD risk by putting them through immunosuppression? And that's the question to answer. So I think that's how we have to frame this disorder. Both the ends, the one that is very benign, it's pretty easy to predict which patients are going to be okay. And the one that's very, very malignant, where you're having a rapidly progressive glomerular disease, you know what to do with that also. The entire controversy in IgA nephropathy is in the middle lanes. What do you do with the person who's got 1 gram of protein, 2 grams of protein, a creatinine of 1.5? He's 30 years old at this time. There's a 50% chance that by the time he's 40, he might be on dialysis. Which 50% are going to end up on dialysis is the quest. And we're all palpating this elephant, trying to look at some of these features to predict what is an acceptable risk for the therapeutic immunosuppression that we are going to dole out to bend the outcome at 10 years for that particular patient. So I think in the interest of letting the discussion continue, I think I'll let Dr. Mateen finish up with his therapeutics thing. And I think we'll come back to Dr. Aurangzeb's case, because I think that's where the entire conversation of IgA nephropathy is.
Thank you, Dr. Agha, for the comprehensive response. So, Dr. Mateen, you want to go back to your slides? Thank you.
Okay, thank you. So regarding the prognostic marker in IgA nephropathy, there are some poor prognosis in the clinical as well as the histopathological findings. In the clinical, when the patient will have hypertension, renal impairment at the time of presentation, the severity of the proteinuria, more will be the proteinuria, more will be the poor prognosis. The prognosis will be poor in smoking, hyperuricemia, having gross obesity, with the long duration of proceeding symptom and increasing age. In the histopathological findings, as Dr. Mudassar mentioned, are mesangial hypercellularity, endocapillary proliferation, segmental glomerulosclerosis, tubular atrophy, interstitial fibrosis, and crescents as well. Surprisingly, the good prognostic factor is recurrent macroscopic hematuria, and gender and serum IgA level having nothing to do with the impact on prognosis. The treatment algorithm is according to KDIGO guidelines. The good prognosis patient with the minor urinary abnormalities with normal GFR, normal tension, and this needs only sporadic follow-up for prolonged period for more than 10 years. In the intermediate prognosis, when there will be a significant proteinuria, hypertension, slow reduction of the GFR, they will particularly benefit from that of the comprehensive supportive care. In the poor prognosis patient, when there will be a rapid loss of GFR, and they will require the aggressive immunosuppression. So in this algorithm, the low risk patient are when there will be isolated microhematuria with or without the proteinuria, which is less than 0.5 gram per day. GFR is normal with no hypertension. There will be only monitoring annually or biannually for at least 10 years. In the intermediate risk, the proteinuria is more than 0.5 to 1 gram per day, with or without the GFR reduction, or without the hypertension. You will optimize supportive therapy with the ACE or ARBs for 3 to 6 months. After 3 to 6 months of the supportive therapy, if the GFR is more than 50 milliliter per minute and the proteinuria is less than 1 gram per day and the GFR remains stable, continue with the supportive therapy. And if the proteinuria raised to or equal to 1 gram per day and there is a decline in GFR, continue with the supportive therapy or add on some immunosuppressor in the form of steroids. When the GFR decreased to that of 30 to 50 milliliter per minute, continue with this supportive therapy, and you can continue with the immunosuppression by keeping in mind of the risk and benefit ratio. And when the GFR is less than 30 milliliter per minute, continue with the supportive therapy. The two distinct presentation of the Ig-A-Nephropathy in the form of nephrotic syndrome or RPGN. Nephrotic syndrome can be treated as a nephrotic syndrome of some other type like minimal change disease. In the crescenteric Ig-A-Nephropathy, you will treat as a crescenteric GN similar to that of other crescenteric GN. Acute kidney injury due to macroscopic macrohematuria, continue with the supportive therapy. So there are some guidelines to continue with that of these measures for the treatment of Ig-A-Nephropathy. Long-term ACE or ARBs treatment, when the proteinuria is more than 1 gram, you can up titrate the drugs depending upon the blood pressure. The target for the proteinuria with ACE or ARBs is less than 1 gram per day, and the blood pressure goal is less than 130 to 80 millimeter of mercury when the proteinuria is less than 1 gram per day, and it is less than 125 to 75 millimeter of mercury when the initial proteinuria is more than 1 gram per day. Role of fish oil is uncertain, will be discussed later by the panel of experts in the treatment of Ig-A-Nephropathy with persistent proteinuria 1 gram per day, despite the optimization of the supportive therapy up to 3 to 6 months. And role of antiplatelet drugs, no role of antiplatelet drugs in Ig-A-Nephropathy. Tonsillectomy, regarding the role of tonsillectomy, KDIGO guidelines does not recommend in Ig-A-Nephropathy, but in the Japanese guidelines, they suggest to use early in the recurrent tonsillitis. There is no role of direct renin inhibitors in Ig-A-Nephropathy. Regarding corticosteroids, when the patient will have persistent proteinuria of more than 1 gram per day, despite 3 to 6 months of optimization with ACE or ARBs, and when the GFR is more than 50 milliliter per minute, they can receive a 6-month course of corticosteroid therapy. Steroids are not indicated when the eGFR is less than 30 milliliter per minute, or when there will be a histological evidence of glomerulosclerosis or tubulointerstitial fibrosis. 2 sets of regime can be used in Ig-A-Nephropathy. In the Pozzi et al., they use the IV bolus injection of 1 gram methylprednisolone for 3 days at each month of 1, 3, and 5 months, which will be followed by oral steroids of 0.5 milligram per kg on alternate day for 6 months. In other regime, there is an oral steroid 6-month treatment of oral steroids with the 0.8 to 1 milligram per day for 2 months, and then reduced by 0.2 milligram per kg per day per month for the next 4 months. There are some trials in which they showed the efficacy of steroids. The one is Stop IgA trial, in which they used, this was done in the European Caucasian. They used the one set of the patient in which total number of 162, 55 patient was put on steroid monotherapy. And the urea and the urine protein excretion ratio rate is more than 0.7 gram per day, and that is less than 3.5 gram per day. The eGFR will be, the eGFR was more than 60 milliliter per minute after 6 months of aggressive renin-angiotensin invasion. This is the open label trial. Baseline proteinuria was 1.6 gram per day. eGFR was 73 milliliter per minute. The steroid regime which was used, that the cyclic methylprednisolone 1 gram monthly at 1, 3, 5 months, and which will be followed by 0.5 milligram per kg prednisolone for once a day for 6 months. Follow-up was of 36 months. Proteinuria at baseline was 1.6 gram per day. Urea protein to creatine ratio at 12 months was 0.5 gram per gram. And the urea protein to creatine ratio at 36 months was 0.57 gram per gram. Full clinical remission occurred in 11, which is 20% of which who received steroids monotherapy and 3% on supportive care. The endpoint was GFR loss of more than 50 milliliter per minute, and there will be no difference between the patient who received supportive measurement and in the patient who received steroid monotherapy. As you will see, in the high GFR group, those patients who receive corticosteroid monotherapy, there will be having a p-value of 0.02. The reduced proteinuria and having a odd ratio of 5.31. In the low GFR, in which they use the cyclophosphamide IV for 3 months, which then be substituted with the azathioprine and steroids, there is no difference between immunosuppressive therapy and supportive care. Regarding the decrease in GFR, there is no difference in the corticosteroid monotherapy to the supportive group and immunosuppression therapy with the supportive group. There is also a testing 1 trial in which they used to see the effects of steroids. This testing 1 trial was on 95% of the Chinese population. Total number of the patient was 262, and the protein excretion rate was more than 1 gram per day. The eGFR range of the eGFR is 20 to 120 milliliter per minute. This was a placebo controlled, and this was steroid was added to after aggressive RAS inhibition. Baseline proteinuria was 2.4 gram per day, eGFR 59.4 milliliter per minute, and the steroid regime which was used as a daily methylprednisolone, which was 0.6 to 0.8 milligram per kg per day, maximum of 48 milligram per day for 2 months, and then taper off over 4 to 6 months. The follow-up was of 2.1 years. At this trial was prematurely stopped because of safety. There was increased number of infection related to steroids. As see, there is a marked reduction of urinary protein in the methylprednisolone group as compared to placebo, and the fall on the GFR is also very prominent in the methylprednisolone group as compared to placebo. So the testing 2 trial, which is in progress, they enrolled the 500 patients taken from China, Australia, Malaysia, India, and Canada, but not from USA. This is a placebo-controlled double-blind Ig-A-Nephropathy stratified by Oxford Massey, and eGFR ranges between 20 to 120 milliliter per minute. Urinary protein excretion rate is more than 1 gram per day with the 5 years follow-up. The regime was same, either the low dose of methylprednisolone at 0.4 milligram per kg per day with the maximum of 32 and the minimum of 24 milligram per day for 2 months, then taper to 0 over 6 to 9 months. Prophylaxis was given for the PJP infections. Primary outcomes in 3 to 5 years is 40% decline in eGFR, end-stage renal disease or renal death in 1 year, and the ratio of urinary protein to creatinine ratio with eGFR at 6 and 12 months. The results will be expected in 2023. In an Nephrology trial, they used the target release formulation of budesonide. This budesonide is 1.5 to 2 times more potent as prednisolone. The mechanism of Nefecon, this release steroid in the ileum, where it acts locally and then absorbed to undergo first pass hepatic metabolism. 150 subjects were enrolled with the biopsy-proven IgA. 50% were given placebo. 51 patients were given 8 milligram of Nefecon per day, and 49 of patients were given Nefecon 60 milligram high dose. With the urinary protein excretion ratio, urinary protein excretion is more than 0.57 gram per day after 6 months of taking ACE and ARBs. Treatment period was 9 months and follow-up up to 12 months. The endpoint was mean change in urine protein to creatinine ratio from baseline at 9 months. These were the baseline characteristics. Urinary protein to creatinine ratio is 0.8 gram per day. With the urinary protein, excretion rate is 1.2 gram per day, eGFR of 78, and the blood pressure of 120/70 over 80 millimeter of mercury. In the results at 9 months, urinary protein to creatinine ratio decreased by 27.3% in 49 patients who received high dose of Nefecon and 21.5% in 51 patients who received 8 milligram per day. But in the placebo group, the urinary protein to creatinine ratio increased to 2.7. In the continuation of this, there is a phase 3 trial in progress. Regarding the role of other immunosuppressants.
Dr. Mateen, let me kind of pause right here. Thank you very much for the overview of the STOP IgAN and then the testing and NEFIGAN trials. And I think these are the trials that we kind of look at to answer the most important question in IgA therapeutics, and that is whether we should give these patients steroids or not. So I'm going to make 2 or 3 general points, and then we'll kind of open this to everybody to see what people think about steroids in this circumstance. So the first thing is, when Pazzi and Mano and then Lev did their initial studies, now this is pre-2010. So when you look at steroids in IgA, you can actually divide the eras, pre-2010 and post-2010. And the most important difference in these 2 eras is maximization of conventional therapy, maximization of ACE inhibitors and ARBs and antiproteinuric therapy, and control of blood pressure. And a very important point to make here is that when you look at STOP IgAN, they started screening patients and they put them on an ACE inhibitor or ARB and they control their blood pressure. And you know what happened? About 1/3 of the patients who are being screened actually could not be enrolled in the trial because their numbers got so better. The proteinuria went away. So I think without question in IgA, the first objective of treatment is to put them on an ACE inhibitor or an ARB and control their blood pressure and control their lipids and do all the things that we can do to improve their kidney and cardiovascular health. That's the first point. The second point is it brings into question proteinuria as an endpoint, right? And so if you look at STOP IgAN, the proteinuria dropped. There was a definite signal towards improvement of proteinuria. Yet their GFRs, if you look at the GFRs in the graphic that you showed, the GFR in the treatment group and the control group are entirely overlappable. So at 3 years, there was no difference in the GFR. And the point to make here is that this is a very slowly progressive disease. And perhaps 3 years may not be a long enough interval to start appreciating a difference in GFR. But when you look at the 10-year follow-up on the STOP IgAN control, there's no difference in ESRD, there's no difference in GFR. So although the proteinuria signal got better in the STOP IgAN cohort, it didn't translate into more meaningful outcomes. I mean, what do I care how much proteinuria the patient has? What I care about is, are they starting dialysis or not, and am I steering them away from there? But the signal was very different in the testing trial. So testing trial, again, is a modern era trial. So they had ACEs, they had ARBs, they had blood pressure control. So they did it the right way. They brought patients in. This was a Chinese cohort mostly. And so when they put people on treatment, it was very unfortunate. I think they recruited, out of memory, somewhere around 250 odd patients. They were supposed to recruit 700. They interrupted it after 1 or 2 years or something like that. But what they were beginning to see, even in that period, was a definite signal towards improvement of proteinuria. And it may have actually translated into a signal of improved GFR, but we would never know because, the trial was stopped. The problem with what happened with testing was that they did not have patients on PJP prophylaxis. So they had 2 deaths. Out of the 20 SAEs, they had 2 deaths, and both of them were PJPs. And so it was a little bit of a trial design error where they opened themselves up to this mistake, and the entire trial suffered. The testing 2 trial will probably answer this question. They've adjusted the steroid dose down, and they have also put in PJP prophylaxis, as you discussed. So based on this, there's this controversy that still rages in the world of nephrology and GN, is that should we give steroids to these patients, and would that make a difference? So what does everybody think? What is your practice? So the case that Dr. Aurangzeb presented, the first and foremost thing to do in that patient is, in my mind, is to control their blood pressure and put them on the maximum tolerated RAS inhibitor dose that is possible. And there's one other intriguing question I'll put up, towards the end of my comments, but that's the first thing. But let's stipulate that it's 3 months later, the blood pressure is 120/80, they're on 40 of lisinopril, and there is 1.5 grams of protein by ratio. What do you do then? What are the options at that point? And what would all the clinicians on this forum, what would you prefer to do based on in light of all the trials that Dr. Akram has so succinctly presented to us? So what do you guys think?
Please go ahead, Dr. Aurangzeb.
Yeah, because I'm here to get answers. I do have my opinion regarding it, but I'll disclose that towards the end of the presentation. But the thing is, this Ig-A-Nephropathy stop, this was a European Caucasian trial. And then we call Asian trial, our testing 1 trial has to be Asian, but it was almost purely Chinese. So the thing is, the crescents are not really prevalent in Ig-A-Nephropathy in European Caucasian population. And when we are talking about that the crescents are almost 5 to 10% in number that we are talking about, I tell that to my fellows that we are talking about IgA crescentic nephropathy. And that is 50% of the glomeruli are having crescents. But if we are talking about IgA nephropathy having crescents, there may be of any percentage that may go up to 36% in Southeast Asians. That means us, Chinese, and then if you go into Caucasian and some other nations, the crescent percentage goes down the list. And that's the reason that IgA nephropathy did not include the MES score. The STOP IgA-AN trial did not include the MES score to begin with. And even in the testing 1 trial, if I'm not wrong, initially the MES score wasn't included. It was only in the retrospect that MES score was calculated in all the biopsies once it was held.
It's the other way. So Stop IgAN did not have the MES score initially, but then they rehashed the data deploying MES score, and it really didn't change anything. And testing reported MES scores from the get-go.
So this crescent, if it's a problem of the Southeast Asians and precisely speaking Asians, so we need to be a little more careful about interpretation of a STOP IgA-AN like a European Caucasian trial, and we have to tailor that decision towards our problem or a nature of disease that is quite different in the Southeast Asians. So first of all, this 50% number, the crescentic IgA, and the IgA with crescent, that should be differentiated. And the answer and the question lies and the dilemma lies, if it's not crescentic IgN and the crescents are less than 25% or maybe 40%, then what to do? And what is the usual practice of everybody? How do they take it? And let's suppose, if I may ask, for example, just like you told me that the MES score, if it's 0, that's good. We don't have any confusion. If it's maximum, we also don't have any confusion. It's the mid where we need to think what to do. But this MES score precisely, now it is being utilized by many of the trials. So we may end up having some kind of guidance at what score do what. But as of now, this score precisely isn't helping me in taking clinical decision. And if I may add, if we go for the international risk stratification score that everybody can calculate on QXMD, and that's what I use as calculator for Ig-A-Nephropathy, it helps us to tell the patient what is the risk at 2 years, 5 years, and all that. But then again, entering all that clinical information that includes if what is the age, what is the race, and even in that, the race that is entered in that international risk stratification score, that includes Chinese, Europeans, and Caucasians, and one Japanese, Chinese, and your Caucasian population. It does not include Southeast Asian because they haven't studied Southeast Asian in that number in order to generalize those results. So those scores are not going to help me in taking clinical decision, or if they are helping anybody in one of my colleagues regarding these scores, I'll be all ears in order to learn how to use it. A very last thing regarding the comment Dr. Aga made about the decision of ACE inhibitor and ARBs. Let's suppose just like this patient is having a serum creatinine of 1.4 and it jumps to 1.7, and he is presenting to me for with IgA with crescent. Now I want to know that if I am giving some kind of immunosuppression, is it working? On the other hand, I want to start with the ACE inhibitor and ARBs. So if there is a rise in serum creatinine, initial rise, let's suppose 20% with ACE inhibitor and ARBs, I'm not going to stop that ACE inhibitor and ARBs, of course. But would that make me a little more compromised in terms of monitoring if the serum creatinine really went down after that immunosuppression? And did that crescent and the inflammation did respond to that kind of immunosuppression that I did? So can we wait for some time in IgA with crescent by starting steroids and then wait for a while before starting ACE inhibitor, or it should start from the get-go with immunosuppression?
Is there a question for me?
Yeah.
Okay. So there's a lot to unpack in what you've said, and let's kind of start taking this step by step. So the first thing is, what is the significance of a crescent that you see on a biopsy in IgA? So let's take the example of the case that you had presented. There is one fibrocellular crescent without any endocapillary proliferation in there, right? Now, you have to kind of look back at how crescents are generated. So crescent is actually a manifestation of a break in the glomerular basement membrane. So essentially all that happens is the glomerular basement membrane breaks, stuff from inside the capillary oozes into the urinary space. That leads to parietal cell hyperplasia, and you develop a crescent. Now, this essentially tells you, in this particular case, the way I would interpret this biopsy, this essentially tells you that there was an endocapillary proliferative or hypercellular response, if I want to keep Dr. Mudassar happy, because they're walking away from this proliferation term. And there was hypercellularity, there was a break in the glomerular basement membrane, a crescent formed, and now that crescent is healing by fibrosis, right? So that's your fibrocellular crescent. So the crescent that you see on this particular biopsy is a fibrocellular crescent. There is absolutely no endocapillary hypercellularity. This is a tombstone. This doesn't tell me that there is active inflammation in the glomerulus at this time to create crescentic disease. Now, this is why I wanted from the get-go to impress that these percentages shouldn't blind us. These percentages can be subject to a lot of variation, and you're cognizant of that. So if there's 40 gloms and you see 2 of those, that percentage is going to be very different than if you see the same 2 gloms with fibrocellular crescents in 5 gloms, from a biopsy sample of 5 gloms. So that's the first thing, that you have to kind of tease that out. Now, there's another type of crescentic disease that happens in Ig-A-Nephropathy, where you see fibrinoid necrosis, where you see diffuse crescents. There are cellular crescents, and the patient's creatinine is burning, right? It was 1, then 1.5, then 2, 2.5. That's the type of crescentic disease where you're running out with your vials of solumedrol and cyclophosphamide, because that disease essentially behaves as ANCA-associated vasculitis. It is just like that, and it is entirely possible that there's anti-endothelial cellular antibodies there, and they are actually, and your anti-gliadin antibodies have got nothing to do with this. It is a totally different type of antibody which is behaving exactly like an ANCA-associated vasculitis. And this is the difference that you see in the vascular lesion that you see in Henoch-Schönlein purpura versus your classic IgA nephropathy. So the biologic behavior of the 2 disorders may be quite different. And so when you see crescents on these biopsies, you have to interpret them based on a lot of different things. You have to interpret them. Is there necrosis there? Is there endocapillary hypercellularity there? Am I looking at a very aggressive, angry glomerulus or not? If you see one odd fibrocellular crescent, that just tells you that at some point there was IgA activity over there, but you don't see active activity at this point. And that is why when you look at these fibrocellular crescents on the biopsies, most of these trials ignore them. They don't even talk about them because they've already excluded patients who have aggressive disease. So nobody in STOP IgAN who had a GFR drop of more than 30% in the run-in period ever made it to the trial. Those people had too hot of a disease. Those people, there's no question they need to be immunosuppressed. You want to put them, and even in STOP IgAN, people whose GFR was between 30 and 60, so they made them, the treatment cohort was in 2 different buckets. The first bucket was where the GFR was between 60 and 90. They got steroids only, and they got the POSI regime. And the bucket between 30 and 60, they got cyclophosphamide. They got cyclophosphamide at a dose of 1.5 mg per kg for 3 months. So they were treated as if they had aggressive disease to try to see if they can bend the eventual outcome. But anybody who had maybe the more aggressive, progressive loss of GFR type phenotype, they were excluded from these trials. The only patients that are included in these trials, STOP IgAN, testing 1, testing 2 now, or the NephGAN, and now the ongoing NephIGARD, all of these trials have included patients who are in that middle zone, who've got a simmer but no boil. So if you've got boiling IgA, if you've got diffuse crescentic disease or significant hypercellularity on the biopsy, we're not talking about whether we want to give them steroids or not. We're talking about how much steroids should we give them, and should we give them cyclophosphamide or not. So the conversation that we have in IgA, where we need to see what we're trying to do here, is in the patients who have got this mesangial proliferative IgA with some fibrosis going on, and maybe a crescent here and a crescent there, which are usually fibrocellular when we biopsy them, because that just tells me IgA is a focal disease, right? It is not a diffuse proliferative disease. There's mesangial proliferation, but the hypercellularity is usually focal. That is why you get so much segmental scar in this disease eventually, because those areas scar up. And so essentially in those focal areas, sometimes you're going to have a break of the basement membrane. Sometimes you're going to have a crescent develop, which then heals up because the disease is simmering. It's not burning. If the disease is burning, you're going to see the creatinine go up. You're going to see the protein go up. that's a totally different bucket. There's no two things about that. If you got significantly progressive IgA nephropathy with diffuse crescents or a lot of endocapillary hypercellularity, you're going to immunosuppress them. That's a proliferative disease then. But we are talking about mesangial proliferative IgA with not a lot of activity. And now you're trying to figure out, what do I do with this person? Does that make some sense? So
And very last thing,
I'm trying to focus back on the case that you have, because to my mind, so I mean, if in this particular patient, the patient that you've just presented, if your M was 2 and your E was 2 and your C was 1 or 2 with cellular crescents, pretty much anybody on this panel would say, let's immunosuppress them because this kidney is going to burn. But we are talking about the guy with M1, E0, not a lot of fibrosis. So what we worry about this stratum of patients, like the patient you have, is that they've got nibbling of the kidney over a period of time. And are we going to change the trajectory of their outcome? And the outcome is GFR and end-stage renal disease at 10 years. Are we going to change the trajectory of that by giving them steroids? That is the question.
and also I would like the house to be open regarding, there are so many new therapies that we are talking about, like mycophenolate mofetil in South Asian population. It has some role, controversial role, no role. There are all kind of stuff, but it is being practiced, and some of the patients have actually responded. Even Dr. Mateen has some patients, I think 4 of them, that have responded to mycophenolate mofetil. And likewise, hydroxychloroquine in IgA nephropathy. Would you recommend at some stage that we should be tailing down steroids of these patients about a couple of months down the line, and then instituting hydroxychloroquine? And then I would also like to hear about dapagliflozin. What is your opinion in patients who are having persistent proteinuria greater than 1 gram, ACE inhibitor ARBs at the top of the dose? And would you add it, or is it just anecdotal still?
I think Dr. Mateen had some slides about individual immunosuppressant agents. I think.
But that was not actually recommended for that of the IgA nephropathy. Regarding that of the mycophenolate mofetil that is used in that of having a effect on Chinese population, but there is no effect on white population. But the KDIGO guidelines did not recommend that of use of mycophenolate. But I have 4 patients which responded well with the mycophenolate, and they are in remission regarding that of the proteinuria as well. And now for the last 3 or 4 years, they are in remission only with supportive management with ACE or ARBs. Any comment from Irfan, Dr. Irfan, regarding mycophenolate?
I mean, this is can I comment?
Please.
Yes.
Okay, this is Vas Masood. So basically, let's talk about what is the evidence-based medicine is here. I mean, I know that mycophenolate, we can see that, but most of the trial did not show up that it's not recommended. And there are many.
Okay.
But the question is now whether this patient should be on steroids or not, and how long, and if steroid does not work, should go to the next step or not. So that I think we should discuss about this particular case. So have we reached any?
So the question back to
steroids regarding that evidence-based medicine, I would just request that when we are talking about the evidence-based medicine, we need to understand we are talking about the evidence of a European population, Caucasian population, Chinese or South Asians, because there is a slight tilt toward different responses. So if somebody, we haven't done that kind of massive trial, there are only case series and the people have responded. The point is, there is a trend towards, just like Dr. Aga said, that it's going to be more than one animal called as Ig-A-Nephropathy about 1 decade down the line. So maybe the Ig-A-Nephropathy of European population and South Asian and Chinese, it turns out that it has some difference in it. So we just need to keep a skeptical mind before shutting the doors on something. That's what I believe in.
That's a very fair point. So the data for MMF, the only data for MMF is in a South Asian Chinese population. And so that's the recommendation that, and we get to see people of all types of ancestry in the United States. So, we can use MMF in those circumstances. Rituximab, has not been very successful. And I know that breaks your heart, Dr. Afzal, because you like rituximab a lot, but rituximab was not successful. And again, there's reasons for that, and there's things being done. I think towards the end of the slide, we can end of the presentation, we can talk, if you want, a little bit about what's in the pipeline. But I think what Avais said is very important, because I think that is the therapeutic dilemma that we have in clinics every day. And that is why I want everyone to think critically about the problem. What is it that we're seeing on the biopsy? What is going to be the course? And one other point before I forget is that one refinement in IgA prognostication is the inclusion of hematuria as a prognostic indicator. So this is the first glomerulonephritis where hematuria has actually now been demonstrated to have an outcome influence. So Dr. Mateen had said that in one of his slides that hematuria is a good prognostic factor, but most of the other data would suggest that if you have more hematuria, your outcomes are not going to be good. So there's actually a gradation in outcomes. And so it's important to see how much hematuria you're seeing on the UA to help you kind of put them in the right risk box as well. So, Avais, what would you do? Would you give this person steroids or not?
Yes, I think basically the thing is that obviously every patient who is not rapidly progressing should be given 6 months of RR inhibitors. And after that, we have to consider that this is an active disease going on, active inflammation going on. But this patient definitely they need some immunosuppressant therapy. What level of therapy they would be given? I mean, I would start with steroids and see if that is enough, or that would work or not. But definitely, I would definitely give this patient steroids, and obviously would make sure that patient doesn't die of complication from steroids or has complication because of giving all the prophylactic treatment and taking care of the patient. But this is an active inflammation going on, and that need to be treated.
Dr. Ahad wants to say something. I know you have a question.
Yeah, so I've got 2 comments. One comment is, as Dr. Agha very pertinently mentioned, that now I think it's probably the Mayo paper that has come up and said that the more the degree of hematuria, the worse the prognosis. But I think that is that is actually they're sort of counting the number of cells. I think what Dr. Mateen Akram was alluding to was actually macroscopic hematuria, the number of episodes per month. So I think there's 2 different things probably as far as the Mayo paper goes. The second comment I want to make is, as Dr. Avais was alluding to, that it has to be evidence-based medicine. If we're going to say it's evidence-based medicine, I would be very sort of open to say that I think stop IgA probably doesn't work for Pakistan. That is the evidence. It's all Caucasian population. Evidence is that this is largely an Asian disease. There's a lot of data been published. Probably I can't bring there is a paper definitely in C. Jason, it was published. It showed that in Asians it's more aggressive disease, and that paper also quoted that it actually having ancestry and Asian race is a poor prognostic factor. So if you sort of taking Dr. Irfan Agha's words, actually it's that the Asians are probably already simmering with these drugs, with Ig-A-Nephropathy. So that is actually, regardless of what the MEST score is, we respond poorly to immunosuppression and to this RAS inhibition as well. So what I would be more interested was, I would look at the testing 1 trial, and I would actually use that as a subgroup analysis, because that had to be stopped early because of Pneumocystis carinii. And actually that did show in whatever 2.5 years that the curves were sort of separating out in those that were having immunosuppression. So I would want to immunosuppress our patients. And I think that is more or less the practice I do see in Pakistan.
Those are all very fair points, very fair points. So, I will kind of go back to kind of, put some context to what Ahad just said. And that is, if you look at first-degree relatives of people with IgA nephropathy, so you've got somebody with IgA nephropathy, you look at their sister, you look at their cousin, you'll find a vast majority of them have elevated anti-gliadin antibodies. So their autoantibodies are circulating. So that's one part. That's why it's a 4-hit thing. Things have to go wrong at 4 places, more or less, for the disease to present itself. And so this is why it seems that in Asian populations, there's a higher prevalence of those genetic risks that can lead to the multiple steps precipitating the perfect storm of the disease. This is also why the disease is not very common in Africa, because it looks like there's some protective things that are in stable frequency in those populations. So Ahad's points are very, very well taken. Testing was a Chinese population, and testing too is actually recruiting in China and India. So you'll probably get to see some South Asian genes in action over there as well. But yeah, no, Ahad's points are very, very well taken. They're all very fair points. So, you know, who's going to give this guy steroids?
Yeah, Assalamu alaikum, Irfan. Adil here. How are you? Just regarding the point of the crescents, the crescents in Ig-A-Nephropathy, as you described, they are totally different crescents. It is the clinical presentation like an RPGN with crescents which drives your clinical management. If you look at that German author, I don't remember the paper, George Flogy, he showed all these biopsies with normal renal function and more than 50% had crescents. So you don't treat these crescents with normal renal functions with cytotoxic drugs. You still give them a maximum supportive therapy like ACE inhibitors, and if you want to add hydroxychloroquine, that's fine. That was done in a Chinese population. The number 2 point is if you look at the 2010 minus studies which you alluded, was that the benefit of the steroids was more when you have a higher proteinuria. If your proteinuria is less, the benefit of the steroids will be not such much. And the pre-2010 studies, if you look at it, the maximum supportive therapy and the target blood pressures, which Dr. Mateen very beautifully showed in his presentation, was 125 and 30. And if you look at the UK study, which I am very well aware of that time, Bellardi, they used cytoxin to show the effect of the cyclophosphamide on the progression of IgA. The blood pressure in that study was 150 by 90. So it is the clinical presentation rather than the histopathology which needs to be interpreted with caution in these patients.
And and I would hasten to add that in the pre-2010 studies, ACE inhibition actually, in some of these studies, I think it was the Ponzi study, but I may be blanking out on that. The Ponzi study, they actually had people take off ACE inhibitors to enroll them to treatment. So the people were peeled off of ACE inhibition to enroll them. That's what changed with Stop IgAN. And now every IgA nephropathy requires a run-in period where you run a stable dose of ACE inhibitors, good blood pressure control. So we're part of an anti-APRIL antibody study. And it kills me because we look like somebody is going to be a good candidate, and you put them on full dose ACE and control their blood pressure, and then they screen out because they're well controlled. So yeah, Adil's points are well taken.
So one more thing regarding these crescents, I totally agree that the crescentic DNA is 50% plus. But I was just a while back, I think I have gone through the literature in which they were saying that C1, the MES score C1, in which the crescents are 25% or less. Even these patients, when they were given steroids, the prognosis was better. And it's given in more than one paper. I have forgot the name of the author, but I think they will find that in literature. So when we are saying that these crescents are totally different, what do we actually mean? Is it just the behavior of the disease, or we need to see those papers first? I would like to see what was the population base. If those decisions were based only on the European Caucasian population, probably I'm not going to buy them. But if those papers were including the Asian and the South Asian population, which are having the major chunk of the crescents in IgA. Probably we should be focusing on them. So if we are just focusing on the crescentic gene, then there should not be C1 and C2. There should be just C0 and C1, and that's it.
No, Dr. Aurangzeb, nobody is differing with your classification of C1 and C2. We are just saying that they have to be correlated regarding the presentation of the disease. If it is a C1 disease and it is presented like an RPGN, the creatinine has gone from 1 to 3.5, even it is a C1, and there's a necrotizing GN, which Irfan is saying, we are going to give them all cytotoxic therapy and steroids, solomedrol, cyclo, probably plasmapheresis also. We are just debating that if you have a C1 lesion with a creatinine of 0.9 and proteinuria is 1 gram, that patient does not require a cytotoxic or an immunosuppressive therapy.
Okay, this is Avas. Can I say something? So I try to make it simple, this IgA disease, which is not simple at all. So basically there are 3 levels of treatment, in my opinion. One is that when just supportive treatment. And the second level is when patient needs steroids. And third level is when patient have very, very aggressive disease with a lot of crescents and patient needs more than like a cyclophosphamide. So that's the question, is this patient needs just supportive therapy or need steroids? I think probably everybody would agree that this patient does not need cyclophosphamide. That crescent is not those crescent which would need immunosuppressant with cyclophosphamide. So question is, should this patient be given steroids or not to be given?
So in the interest of time, I'll kind of say what I would do with this patient, and then everybody else can agree with that or differ, because this is an area in a gray zone. There's pro and con debates happening all the time at every conference. I think in the past, this recent ASN, there was a pro and con steroid discussion in this stripe of patients. So this is a young person who's already got chronic kidney disease, who's got Ig-A-Nephropathy and some proteinuria. What I would do with this patient is I would put them on an ACE inhibitor. I would watch them for 3 months if they're proteinuria, and this is not an emergency. So this is not something where you need to bring them to the hospital and pulse them with steroids, do this and that, the other. So you put them on an ACE inhibitor, follow them along. In 3 months, if the proteinuria is still above 1 gram, it's a young person, he'll be fine tolerating ACE inhibitors. I mean, if this was a 75-year-old person, I wouldn't bother with that. They'll probably pass away before developing renal failure from this kind of IgA. But somebody who's in their early 30s or late 20s, I forget how old the patient was, I would give them a trial of steroids. I would not hold back from steroids. You have to do it with due care. Anytime you've got somebody on more than 30 milligrams of prednisone a day, you need to put them on PJP prophylaxis. And if you don't do that, eventually somebody will develop PJP, and then you'll get into trouble, and they might get into serious comorbid complications from that. So I would do that. This person does not need cytotoxic therapy. I would not give them cyclophosphamide at this stage. There is a difference, and just to kind of Avas, Einstein said, make everything simple as much as you can, but not simpler. So there's a difference between IgA with crescents and crescentic IgA vasculitis. So one is what this case is. I mean, what if, for the sake of discussion, let's suppose this patient had 30 gloms on that biopsy and 4 fibrocellular crescents, no endocapillary hypercellularity, and mesangial IgA with M1 lesions. I would treat them the same way. Very different if this person had 5 or 6 cellular crescents with an E1 lesion and an M2 lesion. Now I know that this is very aggressive inflammation in there. My inclination to use immunosuppressive therapy, my index to use, my threshold to use immunosuppressive therapy would be way lower. So that's where you have to look at the patient, look at the biopsy, and look at the clinical course. And that dictates your course of action. So I don't think anybody would differ with you that if they've got a bunch of cellular crescents, they've got hypercellularity in the glomeruli, that this person has got fairly active proliferative disease. Again, my apologies to our pathology colleague. I'm just used to, I'm an old man now, and so I'm used to using proliferation, not hypercellularity. But that's a different disease from what Aurangzeb's patient is. Aurangzeb's patient has got no endocapillary hypercellularity. He's got one tombstone of a crescent, and it's an M1 lesion. So the tone of this lesion is lower than of a hypercellular or a proliferative lesion. So in this particular situation, your proteinuria and hematuria will tell you, mostly proteinuria because that's where all the data is. So if this person still has suboptimally controlled proteinuria on maximum RAS inhibition, I would then give them steroids like we discussed. One other thing that I would do is after DAPA-CKD, and you know, in DAPA-CKD, they looked at IgA patients. They were like, correct me somebody if I'm wrong, but about 400 patients who had IgA in that cohort. That's about as many people that were put in stop IgAN and testing one taken together. So testing one was what, 250 odd, stop IgAN was 160 maybe. So that's 400 odd patients. So same amount of patients, and there was a clear benefit of putting them on an SGLT2 inhibitor. So I'd be very, very enticed to put a patient like this on an SGLT2 inhibitor as well. But that's what I would.
Yeah, well, that's the plan. But I may want to add, he's a 27-year-old guy, and he had a jump in creatinine from 1.4 to almost 1.7. And which is really, this is a very slowly progressive disease. We need to keep that in mind. So even if this is a single fibrocellular crescent in an inadequate renal biopsy, I'm not going to needle him again. Keeping that rise in creatinine in mind, I would rather do what my team do. I gave him steroid, and I probably would do that again for anybody who is having a rapid rise in serum creatinine. And even if the crescent is fibrocellular, there isn't any endocapillary proliferation. I would believe there is one. I just did not hit it.
That's pretty reasonable.
Yeah.
That's right.
I think personally, I agree with the young patient. I think if I just look at the patient from the patient perspective, young patient, and we are questioning the biopsy, the adequacy of the biopsy, but you are seeing some evidence on the histopathology about disease activity, plus patients' biological evidence with high creatinine, rise in creatinine and proteinuria. I think what you did is what probably I would have done in the same situation.
Can I just say a few words, Dr. Naman Tarif?
Please.
I think one thing is very clear, has been mentioned by everybody. It's the ACE and ARBs, number one. The change in the rise in the creatinine from 1.4 to 1.7 in Pakistan, the lab differences and, the changes, the percentage of patients coming in from the same lab with a creatinine of 1.4 to 1.7 is very frequent. So I would not jump with 1.4 to 1.7 and start steroids. I will give another few days, a week or two, and just manage accordingly. And the most important thing is the proteinuria. As we can say that, with all these trials from 210 onwards, as Dr. Irfan mentioned, they all have common is the ACE-ARBs and the control of blood pressure. And that is the one that is decreasing the proteinuria. And add on, the DAPA-CKD, maybe that's another thing, to decrease the proteinuria. And all the trials in diabetic kidney disease have shown you control the proteinuria, you end up in long-term disease benefits. Now, in terms of the crescent, recently I had a patient almost last week with a creatinine of 0.5. And I think there were like 2 crescents, and there was no endothelial proliferation. So I just kept the patient on just RAS therapy and would just follow and see, what happens. So I think in this case, I would not start with steroids. I will sit tight on ACE and ARBs, and then, go for the this thing. Plus, other thing in Pakistan is, once you are diagnosed with hematuria and proteinuria, it takes almost 3 to 4 months before the patient gets the biopsy. And so many other treatments have been done already from Hakim and here and there. So you never know. As Dr. Aurangzeb is very fond of finding interstitial nephritis in many patients, one of his, keen interest, and very rightly so. And that could, change a few things here. And once you control the blood pressure in some of these patients aggressively, so they can have just a bump in the creatinine because of these hemodynamic changes. Thank you.
Dr. Tarif, thank you for excellent summary. So I know Dr. Ali Asghar, he wants to say something.
Yeah, just a single point. I agree with all this management and everything. What I was wondering was that the adequacy of biopsy specimen has always been a problem in managing these patients. What we practiced at SIUT is that we have someone from histopathology with a dissecting microscope in the place where we're doing our biopsy, and they evaluate the specimen right away. And if the specimen is not adequate enough, it does not have enough glomeruli, we take another cut. I mean, it would be rare for us to have a biopsy sample with 5 gloms on our core. I mean, we would know it right away, and we would take another core. Is that not a standard practice for everyone?
Well, thank you so much for the comment. That's an excellent way, and I hope we can match your skills and status, but I think we don't have that facility. And we just know in the retrospect that the biopsy was inadequate. But that's a very nice comment. I just wanted to keep the house open for one more thing. And as Dr. Noman has also just talked about my second love after rituximab, interstitial nephritis. So that's what I want to ask. None of the things really takes into account that interstitial inflammation. And I was just listening to Dr. Richard Glossek, and probably he's the only guy in the world that I have listened to who talks about importance of interstitial nephritis in renal biopsy and what to do with it. Let's suppose in MESCO, interstitial nephritis is not really something that you can report and count for. If there is an interstitial inflammation and the glomerulus is showing Ig-A-Nephropathy and the creatinine may be anywhere, how would you or anybody take that into account? Or you feel like the interstitial nephritis is not something that we should be talking about and anything?
So Dr. Mudassir, you want to say something, then maybe I can show everybody like some of those Oxford classification and prognostic factors which I have. So Dr. Mudassir, you're next.
Yeah, only one thing that Dr. Ali Asghar was saying, that there must be the evaluation of biopsy before processing. I think the majority of the biopsies which we are getting in the Shaukat Khanum hospital coming from the outside of hospital. In our hospital, we are getting the fresh biopsy. We see them and we evaluate them, and then we process them. At least 10 glomeruli we can count in the dissecting microscope, and then we can count them. But I think these facilities, I think, not present in the rest of the hospitals in the entire province, and in even KPK. The last thing, sorry, one more minute. This is the question from the nephrologist, that if we see, definitely I see many times fibrinoid necrosis in the Ig-A-Nephropathy, because in the MES criteria, there is no question about the fibrinoid necrosis. There is no score about the fibrinoid necrosis. If we see them, we should report them, and we are reporting them, but this is not included in MES criteria. So what would be the implication if we have fibrinoid necrosis in Ig-A-Nephropathy?
I don't know if Dr. Irfan, you want to take this question, because you mentioned about fibrinoid necrosis.
Yeah. So I mean, if you're seeing fibrinoid necrosis with crescents, then you're worried about a vasculitic process. And so, it is almost like an ANCA type process, which is going on, which at least to me, forces me to start treating these people more aggressively on more on the lines of ANCA-associated vasculitis.
And also, I think in that patient, ANCA should be ordered. And I'm not sure, Irfan, what is your view about IgA-ANCA?
So yeah, they're different disorders. Again, they just share the word IgA in there. So it seems to me, based on, this is data from kids, so maybe Dr. Lainwala can comment, but it seems to me that more of the vasculitic lesions that you see in IgA are because of anti-endothelial cell antibodies.
Omar, can I ask a question?
Yeah, please go ahead.
Okay, actually, we are lucky that we have so many experts, particularly in this particular field and IgA with experience in this field. I'd like to, ask a more practical question like we face every day. Like this patient, who's a young patient who does not need a cyclophosphamide right now, but assume this is a woman, a young woman, and who would need immunosuppressant therapy more than steroids. So what choices would you have other than cyclophosphamide in that patient? If you some reason, whatever reason for reason you don't want to use cyclophosphamide and patient has crescent, patient needs immunosuppressant therapy, what choices we would have in that case? But we face this problem in practically, yes.
Bad choices.
Yep. I think we are limited.
Because in other diseases, we have some other choices than the cyclophosphamide, but is there any other choice in this case? IgA, crescents, or?
Yes, what I would do is, what I would do is, if I'm looking at IgA vasculitis, seeing diffuse crescentic disease, and I can't use cyclophosphamide for any reason, I would probably use rituximab.
You would. Okay, what about in that case, CellCept?
I could, but the data for CellCept is actually worse than that for rituximab, and we're talking about a different disorder here. So, yeah, I'm thinking about it as you asked the question. I would probably use rituximab in preference to cyclophosphamide.
So you have any study rituximab using IgA vasculitis?
No, in IgA, anytime I've used diffuse crescentic disease, I've used IV cyclophosphamide. And just to make a point from a fertility standpoint, 1, 2, or 3 grams of cyclophosphamide are not definitive. So you have to look at the potential risk of losing the kidney versus, the possibility of some fertility issues. But usually you start getting into fertility issues when you've exposed the patient more than 20 grams, with more than 20 grams of cyclophosphamide. So giving them a gram or 2 grams or 3 grams in an IV pulse form to control their crescentic disease has never been an issue. So that's why I'm thinking about the question. I've never actually used rituximab. I've never used MMF in a situation like this. I've always used high-dose steroids, and I've used pulse cyclophosphamide.
Well, the question is, what is the race of that patient? If it's a South Asian, MMF is not that bad choice. And to add to that, there was a case series on bortezomib in such cases, and I think the response was better as compared to rituximab. And they did not, because there was only 8 cases in this series, but they did not compare it with something like an RCT, but the response was good. And I would still like to ask Dr. Irfan Aga, Dr. Masood, and Dr. Umar, or anybody else, what about interstitial nephritis? Would you rate it at some level? Is it important?
Out of all these factors, I think the least important prognostic factor is, I think, endocapillary hypercellularity, in my opinion. But interstitial nephritis is a very important factor, and that also, I think, I don't know what can be done about that, but this is not a good prognostic sign.
Yeah, I think I was trying to share, I shared the screen and I took it off. So you can see that the tubular interstitial nephritis in this. I got this, there was a recent GN course at Columbia. So this is not my slide, but I think this is what I'm showing their work is. So the tubulointerstitial fibrosis is the strongest independent predictor of adverse outcomes. And they have, I think, some comments about the C1 and C2. C2 is predictive of worse outcomes regardless of the immunosuppression. C1, I think the wording is of worse outcome if no immunosuppression, but it's not predictive if the immunosuppression is already used. So I think
this is interstitial fibrosis. I was talking about interstitial nephritis, and I want to make a point. I haven't published the data, but I have seen cases in which there was interstitial nephritis, and otherwise it was so-called quite a boring kind of renal biopsy, and the creatinine was on the rise for some unexplained reason, and it was treated as interstitial nephritis, and the patient creatinine normalized. So I'm populating the data, but let's see how the things go. Once I am above a certain case series, because it's not a structured kind of trial, but I am populating the case series. So it will be interesting. So I just want to know the rest of experience of the rest of the nephrologists in terms of interstitial nephritis, not fibrosis.
So Avas, if you allow me to share anecdote.
Please go ahead. So
I have a patient, I've been following him for the last 10 years now. I just saw him this week, and he just started PD because he developed ESRD. But when he came to me 10 years ago, he moved from Pittsburgh. In Pittsburgh, so his biopsy and everything, all the treatment was done in Pittsburgh 3 years before he actually moved to this area. So his biopsy showed the crescentic IgA. And so he was treated with cyclophosphamide, and then I think things stabilized. So when I started seeing him, I saw that there was rise in creatinine, but his proteinuria was not bad. And he was taking Imuran, which is a thioprine for his eye. There was something going on in his eyes, not uveitis, but some other inflammatory condition. Then he got issues with gout, so I switched his Imuran to Cellcept, so I can use allopurinol on him. And with the Cellcept, and this is again anecdote, I'm not just like, I noted that his creatinine actually came down slowly, and then it stabilized, and he actually had many years without dialysis. He was told that within 3 months, 10 years ago, that he would go on dialysis, but then he has done well. So I noted clinically improvement both in his creatinine, proteinuria, and once or twice I just looked closely in the number of cells we see on the hematuria. But again, I think that was probably not the best indicator. So I kept him on MMF, ACE inhibition, and then I think he had like a lot of time without having more progression towards needing dialysis. And then he slowly, this past year, he got COVID and some other problems. So I think he got multiple hits. So he's now on dialysis. So again, I think this is anecdote. And I agree with the MMF data. I think I'm showing on the screen again. It's weak, but I think in Chinese population, it has been, I think, recommended as a steroid sparing therapy.
No, I think it's important that, as Dr. Manzoor said, that we have to figure out that which population we are talking about and which medication regimen works for them. That's important too, yes.
Yeah, Dr. Mudassar is here.
I see him, he is here.
Dr. Mudassar, I have a couple of questions in relation to your biopsies in the last week.
Okay.
Okay. Mudassar, what is the, we know in this sclerotic glomeruli, there is non-specific trapping of IgM-C3. I've seen a few biopsies in the last now 3 weeks. You reported on that sclerotic glomeruli, a lot of IgA in the sclerotic glomeruli. And there was no other trapping of the immunofluorescence. And they said that the diagnosis was saying strong suspicion of Ig-A-Nephropathy. So this trapping of IgA in a sclerotic glomeruli where other things, there is no other trapping. How is it significant regarding the diagnosis of Ig-A-Nephropathy? And the second question is that how frequently you see the full house immunofluorescence pattern with an IgA dominant in a case with Ig-A-Nephropathy outside the lupus?
Yeah, regarding the first question, I think in the sclerotic glomerulus, IgA entrapped can be seen, but I think and I believe that this is not Ig-A-Nephropathy, because in the sclerotic glomerulus, we can see the different types of deposits. Okay, and the IgA is the most notorious deposit which can be seen in the sclerotic glomerulus. So this doesn't mean that this is Ig-A-Nephropathy when and the representative glomerulus is the sclerotic. So this is the answer of the first question. And the second thing is, in the IgA dominant nephropathy, which is post-infectious usually on account of Staph aureus, if I believe. In this case, we can see the full house, but C1q and IgG, they would be, the intensity of these deposits would be less than IgA, but we can see sometimes full house. But there's definitely there is variation in the intensity, because intensity of the IgA would be maximum, and then C3 and C1q and IgM and IgG, they will be mild staining, or sometimes there is no staining. But we can see, but with the history, with the clinical findings, I think these are also very important, just to see the immunofluorescence and then report that this is a full house lupus.
Thank you.
So Mudassir bhai, there is one thing that sclerotic glomerulus has IgA or doesn't have it. I think I have shared with you on WhatsApp regarding our next research product. In Kidney International, there is an article published, I think in 2020, in which, in order to differentiate IgA dominant post-infectious GN and Ig-A-Nephropathy, that was the thing. They said in the sclerotic glomerulus, if there isn't any IgA, it's most probably post-infectious IgA dominant disease, in which IgA deposits wasn't that much. And so by the time it got sclerotic, the mesangial deposits were gone. But in Ig-A-Nephropathy, even in the sclerotic glomerulus, they did find IgA deposits. That's what I remember from 2020, a paper in Kidney International. I forgot the name of the author again.
Okay, you can share the paper with me, but then there is another difference, that we see a segmentally sclerotic glomerulus or we see a globally sclerotic glomerulus. So there is
No,
I
I was
don't remember
talking of
that.
the globally sclerotic glomeruli only in the sclerotic. Rest, there was no immunofluorescence trapping in any other area in the mesangial area.
Yeah, and the globally sclerotic glomerulus, we can see the funny things, and the recommendation is not to report it actually. You can mention it, but on the basis of globally sclerotic glomerulus, we cannot give a categorical, overt or black and white diagnosis that this is Ig-A-Nephropathy.
Because the preserved glomeruli, they did not comment on the immunofluorescence.
But if in the preserved glomerulus, there is no immunofluorescence, we cannot report it actually. We can mention it that this is the IF presentation in the globally sclerotic glomerulus. But in the other glomerulus, there is no IF.
Okay, how many folks
I think
fish oil for these patients as supportive therapy?
For supportive therapy?
Fish oil, any role?
Fish oil, no.
Dr. Mateen will comment on it, I think.
Dr. Mateen, what do you think? Fish oil, yes or no?
I think
No.
Dr. Mateen has a few slides left, so you want to rattle through them. Dr. Mateen, just kind of finish up what you had.
Yes, I think that's a great idea.
Actually, these are the therapies which are actually not evidence-based and they are not recommended. Just Few words regarding that of the cyclophosphamide, which was used in combination with warfarin and dipyridamole in 2 randomized controls with inconsistent results, and both showed modest reduction in proteinuria. The cyclophosphamide is also used, followed by azathioprine in the STOP IgA trial, and there will be there is no difference in improving proteinuria and reduction of and improving of eGFR as compared to supportive group. Azathioprine not recommended, and there is no any randomized control trial to use azathioprine in Ig-A-Nephropathy. Regarding mycophenolate, as discussed earlier, 3 trials in white patients failed to demonstrate a benefit. Chinese patient noted reduced proteinuria and improvement of the GFR only in the Chinese population. In another Chinese trial, there is an improvement of proteinuria, but there is a 4 out of 32 died because of pneumocystis pneumonia. So MMF is therefore not recommended by the KDIGO guideline in patient with intermediate risk of Ig-A-Nephropathy. Cyclosporin has been used in 1 control trial in IgN, but it's only showed the reversible decrease in proteinuria along with a decrease in GFR. This probably is due to that of its hemodynamic effect of cyclosporin rather than immunomodulating effect. Rituximab, sorry, Dr. Aurangzeb, 2 infusion of 1 gram failed to reduce level of autoantibodies against IgA in small open label trial and in patient with the high risk IgA, and there is no effect on proteinuria over the course of 1 year. Sorry, Dr. Aurangzeb. Immunoglobulins, they are used in some trials and there were encouraging results. The proteinuria was reduced, deterioration of GFR slowed down, and there is a histological improvement on repeated renal biopsies. But there is no randomized control is available for this use of immunoglobulins. Crescenteric GN, as discussed earlier, treat as a other crescenteric GN. No role of dipyridamole and warfarin. So these are the new emerging therapies for the treatment of Ig-A-Nephropathy. There is also a B cell activating factors and the APPNA target therapies. Atacicept, this blocks the activation of B cell, and also belicimab, selective antagonist of B cell activating factor. Spleen tyrosine kinase inhibitor, fostamatinib, this will selectively tyrosine kinase inhibitor, and they modulate different B cell related pathogenic pathways in Ig-A-Nephropathy. Regarding hydroxychloroquine, this will reduce the inflammatory cells autoantigen presentation, and there is a inhibition of toll-like receptors and also a reduction of cytokine production. Botulisib, plasma cell proteasome inhibitor that could target antibody production in Ig-A-Nephropathy, and the target for the complement inhibitors like C5a, receptor blocker, avacopan. This will also suppress the local inflammation Ig-A-Nephropathy. And also there are LNP023 complement factor B inhibiting factors and the OMS 721 mannose binding lectins associated serine proteinase inhibitor to reduce lectin pathway. So regarding emerging therapies, I would like to have a comment from Dr. Aga for these emerging therapies.
Well, so if you really look at the way these emerging therapies are set up, you went through all of them. Those are the things that are in the pipeline. So if you look at the sequence of development of this disease, the first thing is there's an abnormal IgA that is produced, which is deficient of galactose residues, which expose N-acetyl galactosamine to immune attack. You develop antibodies against acetylgalactosamine, and so you have an IgG which is clasped onto the abnormal IgA. That antibody antigen complex essentially then deposits in the mesangium. The reason they deposit in the mesangium is because there's this transferrin receptor which is present on mesangial cells. It's overexpressed on mesangial cells. It's the same transferrin receptor that is in the reticuloendothelial system as well to traffic iron around, but it's overexpressed in the mesangial cells, and that is where this antigen antibody complex is anchored in the mesangium. Once the antigen and antibody complex is anchored over there, it generates an inflammatory response by fixing complement. Um, all evidence suggests that in IgA nephropathy, you don't have the classic pathway involved. You have the mannose binding lectin pathway, or the lectin pathway, as well as the alternate complement proteins that are involved in this. And then once that happens, you develop an inflammatory response. So the cells, the drugs that are in pipeline, which I think will have some feet, are first of all, drugs that target antibody production. So there is a trial ongoing using obinutuzumab, which is the newer, better rituximab. And it actually penetrates tissue well, because the thinking behind rituximab's failure in affecting outcomes in what seems to be an antibody producing disease paradigm is that it doesn't affect the malt tissue that well. So obinutuzumab can get into the malt tissue, and we think that that will perform better. And obviously, when there's signaling going on, when there's the gut dietary antigens or bugs that come in and start signaling through antigen presenting cells and then T cells and B cells, BAF and APRIL are involved. So there's a lot of trials ongoing with anti-APRIL antibodies, which seem to work locally, and atacicept, which is a blocker of BCMA and BAF, sorry, of both BAF and APRIL, not BCMA, which then would decrease the T and B cell interaction and lead to decreased conversion of B cells into plasma cells, producing these abnormal antibodies. There is a spleen tyrosine kinase inhibitor, which is called fostamatinib. They've named the drug after Dr. Mateen, it looks like. So it's got Dr. Mateen's name in its middle. And that drug actually leads to decreased signaling in the spleen, and we think will lead to decreased antibody production. There's been some anecdotal data, like Dr. Aurangzeb mentioned, with bortezomib, but there's no controlled trial for that at this time. And then finally, there's a lot of interest in decreasing inflammation at the glomerular level by using anti-complement proteins. So avacopan is being used in a trial. And then there's a trial which is looking at a MASP blocker, which is your lectin pathway. The OMS 721 is a MASP mannose-associated serine protease, which is an integral feculin in the lectin pathway. And that the antibody to that is OMS 721, and there's phase 2 trials ongoing about that. And then there's some trials trying to target the alternate pathway as well. So there's a huge chunk of antibodies and treatment pathways that are being used. And so we'll hopefully in the next 5-7 years have way more tools at our disposal to treat this disease.
Okay, I have a question. I mean, sometimes IgA nephropathy present as a rapidly progressive disease. And in my experience, anytime it presents like this, most time it's like IgA vasculitis. You give steroids, you give cyclophosphamide. In that condition, when you like to, throw the kitchen sink, any role of plasmapheresis in that case, that situation, on top of cyclophosphamide or steroids?
That I know of. People do it, but I don't think there's any data that I'm aware of which is definitive. I'm open to other people's input and experience. This would be mostly anecdotal, but for IgA, again, the inflammation is where it is, and you take it away, take the antibody away, it may or may not affect the process in a fast enough fashion. So I think the money is in controlling the inflammation with steroids and taking away antibody production from the B cell source by using cyclophosphamide. But I'm not aware of any data of plasmapheresis in this particular situation. I mean,
I think they are
let's
all
go.
personal opinions.
say
People
that again?
use it. I think they are personal opinions. People use it,
Sure.
but there's no solid RCTs or anything like this.
Sure. And it is a fairly rare occurrence, so it will be very hard to recruit for a rapidly progressive IgA vasculitis to have any sort of power to inform us one way or the other.
And what is the panel's opinion regarding maintenance therapy in crescentic RPGN Ig-A-Nephropathy? Do you use maintenance therapy?
Yes, yes, we do. I mean, actually, I have patient.
Because I use it, that's why I'm saying I've used CellCept.
I'm using the same thing. Yes, I have a patient right now, actually. I'm using that.
And I think this is also a data-free zone, as far as I know.
No, I mean, I have used azathioprine also in the past. I mean, you can use azathioprine, that is more recommended.
No, actually, there's data that we shouldn't use azathioprine. I wouldn't use azathioprine in this circumstance. So yeah, I mean, the way you want to treat this is like a crescentic vasculitis. You place them on cyclophosphamide for a period of time, 3 to 6 months, and after that you can use steroids. Azathioprine actually doesn't work well in IgA-nephropathy. So, you know, it works well in lupus vasculitis. It can work well in ANCA-associated vasculitis, but the numbers for IgA-nephropathy are not good. And again, this is extrapolation because, and again, I want to be careful not to shoot it down blindly. You may be right in using it in using azathioprine in these cases because these cases are not addressed in the trials that we take this message from, that azathioprine is not good. See, these patients, the patient you're talking about, Avas, would be excluded from all these trials. It's a rapidly progressive glomerular lesion. It would not be included in that trial. So I'm actually a little off target when I say don't do it. I think the correct answer is we don't know, but it doesn't sound unreasonable to do it. That's how I would parse it.
And one more thing, when we are talking about the rapidly deteriorating renal function, by that we don't necessarily mean it's a crescentic GN. Rapidly deteriorating renal function can be just more than one thing. And just like monoclonal IgA nephropathy, sometimes it can have a rapid deteriorating function. Along with that, patients are using different kind of drugs, PPIs, they may use NSAIDs, furosemide, and they may develop superadded interstitial nephritis that may also deteriorate the renal function. For that matter, monoclonal IgA or post-infectious IgA, as you have previously mentioned, and all that things can temporarily lead to deteriorating renal function, and we need to bisect them in different ways.
Sure. And what happens in IgA not very infrequently is that when you get diffuse hemorrhage, you get diffuse glomerular hemorrhage, you actually get an ATN because of the blood in the tubules. It just plugs the tubules up, and that gets better. So sometimes you have this what looks like crescentic disease, but when you biopsy them, you don't see crescents. All you see is RBC casts. It almost looks like warfarin nephropathy on biopsy. And so you have to be careful not to overreact in those circumstances also.
So we got 15 minutes on top of
Dr.
the.
Aurangzeb has opened another chapter regarding this monoclonal gammopathy. You know, in IgA nephropathy, there is lambda predominance. So in that case, how will you differentiate between MGRS and IgA nephropathy?
We could have done that differentiation a while ago when Dr. Mudassar was giving us kappa and lambda separate staining, but now that he has lost that stain after COVID, we won't be able to answer that question precisely on the basis of biopsy because there will be kappa restriction if somebody is having an MGRS or a monoclonal gammopathy with IgA variety, and lambda predominance in terms of regular Ig-A-Nephropathy. And of course, the patient of monoclonal gammopathy of IgA would be of older age, and Ig-A-Nephropathy is generally considered to be in the earlier age. That would be different. There are so many other differences just to add to that.
So I was saying it's 16 minutes on top of the 120 minutes limit. So we are 2 hours and 16 minutes into it. Maybe we should wrap up. I think this is IgA is the most common GN, the most diverse presentation, lack of too many treatment options. And there is a hope, I think, with the therapies in the pipeline that we will have targeted therapies. And I am very proud of the most engaged session today. So thank you, thank you, thank you. I think it's either something with the IgA or something with this group, I think, that has triggered a lot of discussion. And that's what we really wanted. That's what we're really hoping for. And I
Maybe
learned
if you
actually a
fly
lot
up.
of new things, so thank you. Anybody else wants to say something before we close?
Thank you very much. Allah.
Thank you very much.
Thank you.
Thanks a lot.
We would be remiss not to thank Dr. Mateen for a very good presentation and a very thorough preparation. Thank you very much for taking
Thank
the
you.
time.
Thank you.
And Dr.
Thank
Mudasser
you,
as
Dr.
well.
Umar.
I think it went very well. Thank you. This was a wonderful session. As I mentioned, it's my like really wish and dream is like we have this kind of engagement and discussion, and that's what happened today. So I'm a happy man today.
Thank you.
Alrighty. I think it's, I don't know what time is in Pakistan. Probably सोने का time हो गया सबका. हजरात सहरी का time